and uroflowmetry. Those machines will give a sound of running water, so that will precipitate micturition. So opening a tap and running the water, the toilet, will help him to pass urine spontaneously. And because of the obvious reason, standing up position is the best posture for a male to pass urine. So with these conservative steps, most of the patients will be passing urine. If fails, then we'll catheterize. Obviously, as you told, we can try a early talk, maybe with a cover of alpha blocker, once the pain relief is achieved. So, in summary, the case one, pure acute retention will need a catheter. Post-operative acute retention, especially the anal surgeries and groin surgeries like inguinal hernia repairs, might go to acute retention. Those patients we try to manage conservatively as much as possible and consider the catheterization as the last. Then we'll have to assess the patient later and think about the future follow-up. Case number 3, we have a relatively young male patient who had a left side ureteric colic few weeks ago. It has gone away with the medication and tamsulosin. Now, yesterday he had dysuria, frequency, and terminal hematuria. When he is passing urine, the initial bit is clear, then the final, there are some few drops of pure blood. Now he is coming to the ED with a 12-hour history of unable to pass urine and he is in severe pain. So what next? Any volunteers? Anyone? Just to have a good guess. So what is the possible thing here? What is your possible diagnosis? Dilip Madanayaka.
This could be
Yeah.
probably a stone stuck at the bladder neck or at the prostatic urethra. So it is unlikely that he might pass it without at this moment. Because, so he needs again a catheterization.
Yeah, sometimes they pass, sometimes not. So not always you will need a catheter, sometimes, but sometimes not. So I accept your answer, but we'll see. So it's an X-ray, it's taken from the internet. So this X-ray, to check a bladder neck stone or a prostatic urethral stone, you need to see the whole length of the pubic symphysis, because the prostatic urethra is around the level of the upper half of the pubic symphysis. That's why the X-ray QUB should include the whole pubic symphysis. So if the X-ray QUB doesn't show, so you can try a X-ray pelvis erect. So that will cover the pubic symphysis area. So as you told, that is commonly due to a stone in the prostatic urethra, or it might have migrated to the distal urethra. So it's on the way to come out. So then if it is in the palpable part of the urethra, it might be palpable or either visible in the urethral meatus. If the stone is non-palpable or non-visible, you can do an X-ray QUB, X-ray pelvis to confirm your diagnosis, check your diagnosis. Then adequate amount of lignocaine gel to the urethra. That is, I usually put 20 milliliters of lignocaine gel and keep it there with a penile clamp or holding with the fingers. Then you can try a larger two-way catheter, because most of the time we don't have large two-way catheters. Rarely we encounter 20 French two-ways. So then we make it a bladder stone. So we make the prostatic urethral or the bladder stone to a bladder stone. then we should refer the patient to the urologist for a cystolitholepsy. It can be done as a routine case, but as he's a young patient, he might not be happy to hang a catheter for the next 4 weeks. So then it better to refer to the urology department early rather than late. So this is for a non-palpable, null visible stone. If a stone is palpable, you can try because it has come a little bit downwards. You can try adequate amount of lignocaine gel and wait until the urethra anesthetized. Sometimes the patient passes urine. If failing, then you will have to consider a catheterization, and it should be a very gentle one because there's high chance of injuring the urethra in this attempt. If it is visible at the meatus, you give a plenal block, and using a fine mosquito forceps, you can gently extract, but be very gentle with the urethra and the meatus. It will cause a stricture or a meatal stenosis. So if you think that you have traumatized the urethra or the meatus a lot, then you consider about a temporary catheter for few days until the wound heals and patient is able to pass urine without a problem. Okay, so if it is a urethral stone, then palpable, visible, or neither. Okay, so that is case number 3. We'll go to case number 4. He's a little bit of a young man, not a very old one. 3 years ago, he had a bulbourethral stricture which was dilated. He was doing self-dilatation or ISD, intermittent self-dilatation, for 1 year, and then he stopped himself. For the last few months, he was having voiding lower tract symptoms and now coming with acute retention. What next? Anyone happy to answer? Or should I name someone, a random person? Eshani Dabari. Eshani. Can you hear me? Or Dilip, are you happy to answer? So we are talking about a urethral stricture probably, and he's in acute retention. So what will be your steps?
Yes, in this case, I will expect a difficult catheterization anyway for this patient. So, because he might have had
Exactly.
stricture now, getting worse. So, if he is
Exactly.
in real distress, so I might consider suprapubic puncture and first release of his retention, and then refer for a urologist. So he might need
Before considering suprapubic aspiration or catheterization, will you try a catheterization, a normal urethral catheterization?
with if a silicone catheter is available, then I may try with the like with after some
What?
infiltrating with gel, and
Okay. What would be
I
the
will try
size of your silicone catheter and why you prefer silicone catheter rather than a rubber catheter?
because it is more stronger than normal Foley catheter, and so it
Yes.
gives. And anyway,
And
this
what is the
patient might be.
gauge?
So for this patient, I'll try something like 14, 16.
So,
Not sure.
Dilip, these urethral strictures, unlike prostatic enlargement, they are very scar tissue and they are very stiff. So, rather than trying a big catheter, I would rather recommend you to try a smaller catheter. Yeah, I agree with you regarding the uh, silicone catheter because it's obviously stiff. So, it should be a smaller catheter rather than a big one. Okay.
Yes.
So if you don't have a silicone catheter, small silicone catheter, what would you try? Just to relieve the agony. You can try a smaller feeding tube as well, just to empty the bladder. So if failing, as you correctly said, you might need a urologist involvement and consider suprapubic cystostomy, either open or a stab. If you are doing a stab cystostomy, just make sure that you are dealing with the distended bladder rather than an empty bladder. Because some of the VUJ stones patients will come as acute retention. They will say they are not passing urine, they want to go, but nothing is coming out. So the VUJ stones, we might mistaken. We might misinterpret it as a urinary retention, and we might attempt a suprapubic cannula or a cystostomy in an empty bladder. So that's a risk to the bowels, as the bladder is not going above the pubic symphysis. So that's a risk. So be careful that make sure before a suprapubic catheterization that you are dealing with a full bladder. Then literally you can have a urological consultation and arrange the next step of management. Case number 5, again, old gentleman. He's coming with, again, acute retention and denies LUTs and with a palpable bladder. So in deep inquiry, you find out that he is having a recent onset nocturnal enuresis. That is, in the deep sleep, he just wakes up with a wetted serum. So easily catheterized and residual volume is high, 1600. So what would be your next step? So case number 1, we discharge, giving some tamsulosin and arranging a trial without catheter session. So anyone to answer? Chandrasekharan? Dr. Chandrasekharan? So it's an old gentleman coming with urinary retention and a huge volume of catheter drainage or the residual volume. Anyone happy to try? Gajendran? Dr. Gajendran Achudan?
Yeah,
Yes,
this patient
thank you.
developed high pressure chronic retention.
Okay, what are the classic features? What are the classic features, Gajendran, of high pressure chronic retention? History examination.
So in the history, usually the elderly patient, in the examination, usually there's a palpable bladder with a non-tender, and patient developed the nocturnal enuresis.
Regarding the bladder, it will be a tense, palpable, non-tender bladder. Three terms. Tense, palpable, non-tender bladder. Tense.
Yes.
Okay.
Yes.
That is one. History.
In the history, ask about the history of any other features suggestive any renal failure or any renal impairment.
So, yeah, the classic feature is nocturnal enuresis. Then you find out there's a tense, non-tender, distended bladder. Number 3. So he will have features of renal failure.
Yes.
Number 4, hypertension. Might or might not be. Yeah. So, and the 4th thing is he will be having upper tract dilatation, bilateral or unilateral, depending on the time duration, there will be upper tract dilatation. So, history examination and investigation, there are classic 5 features. It doesn't need to be all the 5 features, or some of the features might be there, some are not. So, what would be your next step?
So in this patient, I will put the catheter immediately.
Okay, no, so we have put a catheter and the residual volume is documented as 1600.
Then I will go for the ultrasound scan to confirm my diagnosis and to explore the upper tract dilatation and any other changes in the renal.
Before that? before that? Because sometimes ultrasound cannot be arranged immediately. It will take 1 or 2 days sometimes. So you can check the renal functions, especially the creatinine and electrolytes. After the catheterization, these abnormal values, if they are, will come down drastically. The book says it might take until 6 weeks to come to the baseline, the final baseline. But what usually we see is within 1 or 2 days, the creatinine level drastically comes down. So first thing, you have to get admitted the patient. The patient cannot be sent home. Why?
There's a large amount of urine, more than 1000 cc. He found to get the recurrent acute urinary retention and also get the renal impairment.
Another reason?
So
There's a risk of
infection.
Yeah, there's a risk. No, the main reason is all the other facts you just mentioned. I'm agree with them, but the most important reason is these patients will go to post-obstructive diuresis. About 10 to 15 patients. Hello.
Yes, sir.
Will go into post-obstructive diuresis. So therefore, you have to strictly monitor the input-output and the blood pressure, and make sure that the renal functions are in the safe side. And if the potassium, you might need some correction. Previously, historically, we were doing catheter clamping, thinking that it will avoid this post-obstructive diuresis, but it's not practiced anymore. If the urine output is more than 300 per hour, then we conventionally replace 1/3 of that previous hour's urine volume with a normal saline. Not 1-to-1 correction, 1/3 correction. Otherwise, they will keep on diuresing. Once the urine output is stable, you can send home with the catheter and not walk. No trial without catheter, and he will need a surgery for the bladder outflow obstruction. There's no medical management for high pressure chronic retention. Okay, thank you. Then, few things about the difficult catheterization. So it's very stiff. The telltale signs are difficult to insert. There's a tightness, difficult to insert up to the bifurcation. So until the bifurcation, the catheter is not going easily. And once you take your hand away after putting the catheter recoils back from the bifurcation. It comes out few inches rather than staying in. And when you are inflating the balloon, there might be pain. So, and the catheter is not draining and only blood is coming. And you might feel the palpable catheter balloon in the perineum even. So those are the telltale signs or features of difficult catheterization. So mostly strictures, long prostatic urethra, urethral stone, or the commonest thing is if it has been attempted by a non-experienced person or a really difficult catheterization, there it may be a false passage. So anyone know what's this false passage business? Anyone want to guess? Copulant? What is a urethral false passage? So when there's an angle between the bulbourethra and the posterior urethra, when you try to insert a catheter forcefully without adequate lubrication, rather than taking the bend, the 90 degrees turn towards the posterior urethra, the catheter will go straight back, creating a hole in the bulbourethra, so in the posterior aspect. So the catheter will go out of the urethra through that hole. So that is the false tract. Every time you put a new catheter, the catheter goes towards that hole or the false tract. So you will see the pain, catheter is not draining, blood in the tip of the catheter, and blood is draining from the catheter, especially if the patient is taking blood thinners. So you suspect a false catheter, false passage. There are few options. So what to do? Range of catheters. You start with range of catheter with a sensible assistant, blood lightening, and adequate lubrication, and wait until the urethra gets anatherized. Maybe 2 minutes at least. Wait. try a larger catheter or smaller catheter if the catheterization is difficult. In case of long prostatic urethra, a larger catheter. In case of a stricture, smaller catheter, stiff catheter. If you are suspecting a false passage, then curved tip catheters such as 40 tips or T1 tip catheter will help to negotiate that angle. Or you might have used or seen the catheter introducer, which has a curve. It will make the catheter curved frontwards, so it will again negotiate through the rather than going to the false passage. Urologists might try a guided insertion or cystoscopy guided insertion. So in your point, if everything fails, then a suprapubic cystostomy. Okay, thank you. Dr. Kalana.
Sir, one question. Hello?
Do you have any questions?
Yeah, go ahead.
Yes, regarding the clamping after the acute and chronic retention, hypersecondary retention, can we prevent the hematuria by clamping in between 1000 ml? If we clamp it, can we prevent the hematuria, sir?
No, it was all practice actually. Now we don't use this catheter clamping, so we just allow it to drain. And if he produces more urine than expected, then we replace it with the IV normal saline 1/3 for the volume. There's no way of preventing the obstructive hematuria. So you might have to irrigate sometimes even.
Okay, sir.
You might have to change to a 3-way catheter and irrigate. So I would like to hand over the my baton to Dr. Indrajit.
Yeah, thanks, Dr. Sanjeev. Can you hear me?
Yes, we can hear you, Indrajit.
Okay, thanks. Right, I'm sharing my screen. Hope you can see the screen, right?
Yes, we can. Thank you.
Okay, so I'm going to discuss about acute management of visible hematuria in general surgical casualty. So this is again a practical stuff, no much of theory. So it's based on few case scenarios, and so I would like to invite somebody to join with me. Otherwise, it's going to be very boring. So, is there any volunteer to join with me for the discussion? Or may I ask somebody? Can I ask Pramod De Vikramasinghe, a famous name? So, are you okay to join? If anybody uncomfortable is all right, so then we can somebody else. Hello.
Yes.
All right. So you're Pramod there, right?
Can you hear me, sir? Yeah.
Okay. Okay, Pramod there. Right. So the first case is a 73-year-old gentleman who presented to surgical casualty with 1-day history of visible hematuria and passing some clots. So how will you assess this patient initially? Or what is your approach?
First, I'd like to take a if the patient is not hemodynamically unstable, I'd like to take a history and do a proper examination.
Yeah, so and that's good. So you mentioned something about, so this is a surgical emergency, is any condition which causes significant bleeding, we might consider as a surgical emergency. And it's better to mention that you will assess the patient according to ATL's protocol. So, but most of the time, these patients are quite stable hemodynamically, because I think the reason is that they are quite frightened, having blood in their V, so they will present quite early. So they are not often hemodynamically unstable, but sometimes we see quite ill patients. So yeah, so patients clinically stable. So yeah, so what will you concentrate in your history?
The age group, because the age group can give an idea whether it's due to a malignancy or not. Then I took a proper drug history along with a medical history, because if the patient is on antiplatelets and such, it can give rise to bleeding. And the previous surgical history, whether the patient has undergone any urological procedure.
Yeah. Right. Good. So yeah, few things in the history. So as usual, you may ask about the onset of the bleeding and progression, and with the patient is having hematuria each time he's passing urine, and obviously this patient is having significant hematuria, passing blood clots, and then you will ask about proceeding or concurrent LUTs and features suggestive of urinary tract infection. You may quote few symptoms like dysuria, abdominal pain. Then you may ask about any possibility of trauma which might cause hematuria, depending on your history, and then may consider other urological history, previous malignancies, urothelial cancers, or any history of urolithiasis, etc. So then it's important to inquire about the risk factors for certain urological malignancies, particularly urothelial carcinoma. So you may ask about the smoking history and chemical exposure, and hypertension and obesity with regard to renal cell carcinoma and family history of prostate cancer, etc. So, and the other thing is that, this patient is quite old, and most of these patients are on some of blood thinners, and you may ask about any such history, and also the medical condition which might cause any coagulopathy. So those are the key things I would say in the history. So then you will proceed accordingly. So what about the examination? Any key things which you are concentrating on your examination?
Whether the patient is pale, which would indicate like significant blood loss.
Yeah.
And if I'll check the patient's blood pressure and pulse rate, which should again give an idea about his hemodynamic stability. And whether there's visible bleeding at the moment, whether it's whether there's fresh bleeding from the urethral meatus or just on passing urine. And I do an abdominal examination as well.
Yeah. So what are things you are concentrating on your abdominal examination there?
Whether the abdomen is distended.
Yeah.
And if the bladder, if the bladder is palpable, and if the kidneys are
yeah. What means if the bladder is palpable? This is a patient who is passing some.
It could either point towards an obstructed bladder walk.
Yeah, so that's
or
right. So it's mostly suggestive of clot retention in this kind of scenarios. Yeah, that's good. So, and also you will look for any possibility of low in masses. So, and any other important thing as part of your abdominal examination? So then you will do digital rectal examination, right?
Yes, sir.
Yeah, so you have to look for any benign prostate enlargement, or whether there's any suspicious nodule in the prostate, because those are some of the causes which might cause hematuria. So I think you covered most of the thing. So if you have not assessed previously, you have to check heart rate and blood pressure, and then the other things which we have mentioned. When you are doing digital rectal examination, if patient is not in clot retention, you may palpate for any palpable bladder masses. So, but it's quite difficult though. So, but in at least for your exam purposes, you may mention that for additional marks. Good. So, what are the initial investigations you might consider in this patient?
I'd send blood for a full blood count, and I do renal function tests as well.
Yeah.
And I'd like to get an urgent ultrasound scan to see whether there are any large clots in the bladder, and whether we could identify the if there's any obstruction, if there's a stone, whether we can visualize it.
Yeah.
Um,
Yeah.
if
So, okay. So that's a sensible answer. So, yeah. So you will take some. What about having a urine pool report here?
Yeah, I think it's better to go with the UFR as well.
Yeah.
Obviously, there would be red things.
Yeah, but it's very difficult to interpret or examine the urine pool report here having does quite frank hematuria. So you may avoid actually getting a urine pool report, but it's important to send a sample for culture and then take your blood for grouping and saving in case of transfusion, and clotting profile importantly, and pool blood count as you mentioned, and some of the inflammatory markers and renal function test which might give idea about the baseline kidney function, which might be important for future imaging as well. So yeah, so yeah, you can consider ultrasound scan if it is available at, but it's not very important at this stage. So, but yeah, if facility is available, is not a bad idea. Okay, so right, so these patients, when we get these patients, so we are concurrently managing the patients. Actually, we are not waiting to complete the history examination and things like that. So you may start your management in the meantime. So, but for presentation purposes, I have divided into several sides. So how will you manage the patient?
First we should do the initial resuscitations. If the patient's blood pressure is low and if the patient is hemodynamically unstable, we should address that first.
Patient is stable.
In the meantime, I'd like to then I will start a maintenance drip, IV drip, and send blood for DT and cross matching in case the patient needs blood.
Okay.
And I'd like to do a clot evacuation with a 3-way catheter, if possible, if it's available.
Yeah, so of course, 3-way catheter should be available, and it's a key thing in the management of this patient, right? Yeah.
And if clot evacuation with a 3-way catheter fails, I'd like to get senior opinion on clot evacuation with cystoscopy or any surgical method possible.
Right. Thanks. Right. So I think it's very important to reassure the patient. So usually they are, quite frightened having this blood in their V. So it's very important to reassure the patient and say that it's something not uncommon. So, but we need to manage. We have the facilities to manage, and we need per the evaluation. So to come into a conclusion. So you're in safe hand, and also so please consult the patient first, and then yeah, it's the key thing is a 3-way catheter, so it should be appropriately large, right? So don't try with the smallest possible catheter here. So I hope you know how to select the size of catheter. You quickly have a look at the external urethral meatus, which is the narrowest point of the urethra, and select a largest possible catheter, maybe 20 or 22 French, and in the meantime, start with bladder irrigation. So there's no particular rate of saline drip, particular rate is common sense. So if there's frank hematuria, you start it fast and then come down when the urine is getting clear. So obviously, if there's clots, you may do initial bladder washout as well at the time of catheterization, and make sure the clots being evacuated as much as possible. So what is your opinion with regard to antibiotics?
I think it's better to start an antibiotics because it's a good culture medium for bacteria like blood and urine.
Yeah, so that's a common practice, though there's no stiff rule with regard to that. So obviously, if there's features suggestive of urinary tract infection, so you will start. But even prophylactic basis, some people start. So there's no hard and fast rule. Right. So then you may be told the blood thinners, propitocal and things, but you have to liaise with the appropriate medical teams importantly, because there's a reason why patients are on these medications. So you just don't stop yourself, and please discuss with the medical teams appropriately. And then so you evaluate the investigations when they're available and consider transfusion accordingly. And if there's any coagulopathies, you may correct with the help of your hematology team, right? So I think that's the kind of initial management. So then you get a call from, or your sister is calling, or your house officer is telling that the patient is in a bit of agony and the catheter is not draining now. And then how will you approach?
It's probably a clot obstructing the catheter.
Yeah.
So I'd like to flush it out first and see whether it's draining.
Yeah.
If not, we can try and change the catheter and
Yeah.
and put a continuous connect a continuous drip to the catheter for a continuous washout.
Yeah, in these kind of cases, I think it's a sensible thing to continue blood irrigation. So at the from the beginning, actually. So, but despite that, they might go into clot retention. So if there's significant bleeding, so yeah. So one important thing is you should ask to stop your bladder irrigation, right? If it is running and if it is not draining and patient is in agony, so just the fluid is getting into the bladder and it's distending and causing pain, and sometimes can cause some detrimental effects as well. So, right. So, yeah. So then you will check your catheter whether there is any kink or if it is properly placed and all, and then you try flushing the catheter. So easier way to do it that you can change your irrigation fluid into the major draining channel with a little amount of saline. So and then try. So, but if it is not working, so then you try a gentle bladder washout. And how will you do a bladder washout?
We would instill about 20 cc of normal saline into the three-way catheter, and so the clot.
How will you instillate saline into the bladder?
So since it's a three-way catheter, there would be a port that would lead in the catheter with an inlet.
Yeah, you have to use a bladder syringe, right? So, and you have to be very careful with the bladder syringe, particularly if you're using a glass made one. So it's quite fragile. But fortunately nowadays we have disposable plastic bladder syringe. So it's accommodate the catheter channel properly. So you have to have a bladder syringe, and as you said, you get a small amount of saline, so 20 to 50 cc, and then instillate it, and you look at the patient pace while you're doing that, and if he's in quite agony, so you slow down with it and use smaller volume as possible. And because if you forcefully do it, patient might go into it might cause bladder rupture even. So if there's a quite distended bladder, particularly in females, so you just have to be careful and gentle and try to get rid of all the clots as much as possible, and make sure that you are get rid of the fluid which you are instillating. And if there is a positive balance inside the bladder, so you may come down with your volume in the next time. All right. So failing that, you may change the catheter with a large catheter and reattempt it. Okay. So yeah, that's how you sort out a blocked catheter in a case of hematuria. Good. And so patient has been okay for a while, and after some times, the nurse is reporting again that the catheter is getting blocked intermittently and not is passing small clots. So now what will you think?
There would be oozing of blood into the bladder, which is giving rise to smaller clots.
Mhm.
I think we can try either something like tranexamic acid or try bladder irrigation with silver nitrate.
Oh my God. So I think that's quite dangerous at this stage, right? So yeah, kind of same problem. So again, catheter is getting blocked because the bleeding is continuing, and there will be some clot formation. So again, you go into your basics and you assess the patient and look at the catheter and make sure that it's in position, and redo your try bladder washout again. And I think this is the time you have to consider ultrasound scan if you haven't done previously to exclude the possibility of large bladder clots. So uh, you mentioned about tranexamic acid. So what's the problem with tranexamic acid in case of hematuria? Anybody? Hello?
It would mask the symptoms.
Uh,
We would know whether there's ongoing bleeding, whether it's settled.
No,
I'm
the thing is not really that. The tranexamic can cause quite hard bladder clots inside the bladder, which is very difficult to get rid of. So that will cause a lot of trouble to the urologist. So we don't like patient to be given tranexamic acid in case of hematuria. Please avoid that. I think most of the urologists don't like tranexamic acid to be given in these scenarios. And silver nitrate, I think, is inappropriate in this stage, right? So it is indicated in very specific cases because this is, sclerosing agent, and it can cause detrimental effects like bladder scarring and, a lot of problems. So do not consider that at this stage. Okay. Yeah, so you have done ultrasound scan. It's revealed 10 into 8 centimeter large clot inside the bladder. So now what will you do?
And he might need cystoscopic evacuation of a clot.
Good. Yeah. So
So we can use an evacuator, and we can also diatomize if there are bleeding points in the bladder through cystoscopy.
very good. Okay, so I think this is the time you have to contact your urology team. So, but unfortunately, in most of the situations, so some people contact urology at the very beginning of getting these patients, so without doing anything, even not putting a catheter. So basically, you can manage up to this stage, and this is the point where you need your urological to help. So contact the urology team and keep the patient passed in and do pre or for investigations and arrange a theater slot. And so patient will need cystoscopic clot evacuation with or without cystodiatomization. So there's a printing mistake here. Sorry about that. Yeah. So yeah, we have already answered this question. Yeah. So well, so what are the options available if the hematuria is very refractory, so you have done clot evacuation and patient is coming back to your ward and the hematuria is continuing. So what are the next level steps, so highest steps of managing refractory hematuria? These things I think you uh, uh, just to know. So basically, you will not be asked about these steps in detail. So any idea?
We can go for therapeutic arterial embolization.
Very good. Yeah.
With
Anything else? Good. So yeah, so you may evaluate your coagulation profile and transfuse patient appropriately and lies with your hematology team, etc. And yeah, as you mentioned, so you consider angioembolization. This is quite helpful with the help of your intervention radiology team. So so it could be wherever. So maybe in renal bleeding, say for example, after partial nephrectomy. So if there's patient having significant hematuria, we might consider this, particularly having pseudoaneurysm. So, and even after some prostate surgery, right? So it's a quite useful tool in armamentarium of managing acute hematuria. And in palliative setup, having large bladder, a tumor, so you may consider a single dose of radiotherapy to control bleeding. And there are rare instances where patient undergo major procedures such as nephrectomy or cystectomy, even when there is uncontrollable hematuria. Good. So yeah. So
Sir,
yep.
sorry to interrupt. Sir, are
Yeah.
you moving the slide, sir? It's stuck in the fourth slide. After fourth slide, it hasn't moved after that, sir.
Oh, yeah. I was moving, so I don't know what happened. So can you see my slide now?
Yes, sir.
Yeah.
In
So
between,
now,
yeah, in
yeah.
between, I think it's
You couldn't see. Sorry about that. So, but basically, it's just text slides. So I can share with you all. So if you need these slides. So, but now is slide number 22. So there's no time to go back to them. So I hope you understood what we discussed.
yes, yes.
Yeah. So yeah. So now patient stable and the hematuria is somewhat under control. So what are the key investigations in per the evaluation of this patient having significant hematuria, quite elderly, and if you can name two investigation in order to diagnose the cause. Anyone? To save some time. So yeah, we have to consider CT urogram and flexible cystoscopy. So those are the two key investigations in evaluating visible hematuria. So there are certain slight differences in between guidelines, but basically these are the two main investigations. But in male patients, so you may consider a PSA as well. Okay, so I hope you can see the slide, right? Can you see my slides now? Hello.
Yes, so we can see the slides.
Yeah. So somebody else could answer this one. So it's case number 2 based MCQ. So you are attending a 34-year-old male presented after a road traffic accident who is hemodynamically stable. The chest X-rays was right-sided 11th and 12th rib fractures and a stable pubic ramus fracture. He has been catheterized and you see mild to moderate hematuria. What is the key investigation to do in this case? Who is going to answer? Unfortunately, I can't see the name list. Yeah, I can see now. So, right. Dilshan Panandu, would you like to answer? Indunil Lianage?
Yeah, the retrograde urethrogram, I think it is the key investigation to do.
Yeah. Why you are considering retrograde urethrogram?
Because in this case, I'm suspecting there is a urethral injury.
Yeah.
And in retrograde urethrogram, we can see whether there is any contrast leak in the urethra.
So I can't say no, but it will be important if there is significant findings suggestive of having urethral injury, features such as having blood at the meatus and things like that, but it's not mentioned in this case. So it's a road traffic accident, maybe patient is having polytrauma. So he had some rib fractures in the region of the right kidney. So it may be a renal injury. So I think more appropriate to undergo a CT urogram. So it will give a lot of details with regard to the urological tract and anatomical details of the kidneys, etc. So I think I would say a CT urogram on top of retrograde urethrogram, but yeah, so it may be appropriate if there's significant suggestive things for that. So yeah, so it's a case of trauma. So you may get patients having hematuria after trauma. So management will be slightly different with regard to catheterization, etc. So, but I'm not going to go in detail here. But please aware about the investigations and the management of them, right? So next case is a 80 years old gentleman who is on long-term catheter transferred to surgical casualty from a peripheral unit, had been unable to reinsert the catheter on routine changing. The patient reports low abdominal discomfort and some hematuria. He is on low-dose aspirin. Examination revealed tender palpable bladder. You noticed some blood at the meatus. So what will you do? So who would like to answer? Bimsara JA? Ice Kim Han, please. Right. So anyways, yeah, so it's kind of, there may be a pole strength. So it's may not be real hematuria actually, the blood passing some blood per urethra. So but some people may attribute this as hematuria. So the options are given: prior smallest available catheter, cold urology, suprapubic puncture, and urology input. Suprapubic catheter, three-way catheter, and blood irrigation. I think is a bit of difficult one. So I would say suprapubic puncture and urological input. So because most of the time there won't be bleeding backwards into the bladder. So if patient is in discomfort and having palpable bladder, the important thing is to relieve his agony. So you may do suprapubic puncture safely and then sort urological input, because it might be difficult catheterization having previous attempts and possibility of porous tract, etc., as Dr. Sanjeev discussed previously. So the next one is just to complete some of the aspects, brief cases. A 23-year-old construction worker came to surgical casualty with a history of hematuria for 2 days and feeling dizzy. He has taken less fluids for last few days, having fever and reports mild dysuria as well. What is your approach for this patient? So any guess what's going on with this patient possibly? So some of these odd cases coming to surgical casualty may not be surgical itself. So this could be a case of dengue hemorrhagic fever. So having been in dizzy, previous history of fever, right, exposure to areas where the mosquitoes are abundant. So yeah, so quite important to have open mind. So please don't miss some important things like dengue. The next one is a 21-year-old unmarried lady came to casualty with a history of hematuria with clots for 1 day. UFR just shows 5 to 10 red cells and only 10 to 12 WBCs. So patient is okay. And the house officer thinks that can send the patient home with some oral antibiotic possibly. So are you happy with that? So again, the thing which I want to highlight here, so these kind of things, due to some social reason and also patient might not come with proper history, so they may attribute per vaginal bleeding sometimes as hematuria. So it could be a case of ectopic pregnancy. So next hour, patient might collapse. So please don't ignore these things. Uh, uh, Probably the last case, a 64 years old lady with diabetes mellitus and history of cervical cancer managed with radiotherapy 12 years back, coming to you with persistent hematuria despite a recent course of oral antibiotics. What are your concerns? Anybody to try? I don't know how much time I have taken. So if there's time, somebody can try. Any volunteer, please. Well, so this is a case of possibly a radiation cystitis. So it's a quite difficult case to manage. I think these kind of patients, you make so urology input early. So because the management is quite difficult sometimes, and you may need a different approach. So patient might need some intravesical installation as Vikram Singh mentioned previously. So we might consider some alum, sometimes formalin after cystogram to exclude any perforation. So there's a place for hyperbaric oxygen as well. So urinary diversion, etc. So it may be a quite difficult case. Please have some idea about radiation cystitis and hemorrhagic cystitis. So so those are some difficult cases to get urology help in time. I think with that, I would conclude my talk. Thanks for all the participants who helped to get going. And sorry about the slide running issue. Thanks.
Can you hear me? Also,
Yes,
how long?
Yeah,
How long?
Yes,
Radiation cystitis. How long can it be occur after post radiation?
Usually it's after a year's time, so it's not quite right after radiation treatment. So usually patient will present after a few years, at least 12, 18 months, so minimum. So it's usually after a year's time.
In this case, possibility of bladder tumor also should be
Yeah, of course. Yeah. So those investigation should be done. So we are just focusing on the initial management. So obviously this patient will need flexible cystoscopy and CT urogram also. And having radiation therapy, secondary tumors are also possible. There's 1 out of 300 kind of chance there. Any other questions, please? Okay, so in the absence of other questions, may pass.
Thank you, Dr. Indrajit. Can you hear me?
Yeah.
Yeah. So we will move on to the next presentation with Dr. Naling. Are you available, Dr. Naling?
Yeah, I'm here. Can you hear me?
Yes.
Okay, thanks. Can I share my slides, please?
Yes, please.
Dr. Indrajit, I think you have to stop sharing.
Yeah, how can I do
slides?
that? I'm trying to do that.
And then I can. You just go to share and yeah.
Is that okay
and
now?
The host has to let me. Yeah, I think so. And the host has to let me share my slides. I'm not a host now. Okay. Yeah. Can you see my slides now?
Yes, you can see.
Yeah. So I'm sorry about the presentation here. My presentation on the cases are not opening up for some reason. I don't know why. But I'm going to discuss all the theoretical stuff here, and I'm going to discuss the cases as well without slides. So the first case I'm going to discuss is a 45-year-old gentleman, farmer from Hambantota, comes with a right-sided abdominal pain for 4 hours duration. And you are the surgical registrar in your casualty setting. And how are you going to approach this patient? Anyone, any volunteers, or should I name someone? Can I ask someone to, shall I pick someone?
Yes, Nalin, I think
Madhushankar. Madhushankar. Madhushankar WIS. No. Melan Jaisingha. No.
Yeah, hello, sir.
Can you hear me? Melan, is that Melan?
Yes, sir. Yes, I can hear.
Yeah, so you have a patient, a 45-year-old farmer from Hambantota, coming with acute onset right-sided abdominal pain for 4 hours duration. How are you going to approach this patient?
First, I will take a short history from the patient, and I will ask for the associated symptoms as well. For example, he has nausea, vomiting, and I would consider a number of diagnoses. First, I would think of it if it's an acute abdomen.
Okay, good. Okay. Yeah,
and I would check the hemodynamic status of the patient.
Okay, good.
And if the patient is hemodynamically unstable, first I would attempt to resuscitate the patient.
Okay.
And then
hemodynamically stable, usually this type of.
yes. And then after that, I would proceed to do a focused examination on the patient as well. And
we'll first focus on the history, Melan. And what are the specific features of pain that you're going to elicit on your history?
So I will ask him about the site of the pain, and for how long the pain has been there, and the character of the pain, and if the pain is radiating, and if there are any associated other symptoms like nausea, vomiting, and the severity of the pain.
And
then along.
So I'll stop there and explain the natural history of the pain or the phases of the ureteric colic. We'll come back to Melan again. Can you see my third slide? So these type of patients, when they're coming with right-sided abdominal pain, you should have your differentials, including acute appendicitis, cholecystitis, if it is upper abdominal pain. And particularly if the patient is like 70s or in his 70s or 80s, you should always consider a leaking triple and AAA. So that's one of the most important differentials that you should consider in your history if the patient is an elderly man. But in this particular case, this was 45 years. So I would not consider a leaking AAA in this patient, but you should have it in your mind. But in terms of the history, when you are taking the history, you should concentrate on how this pain developed. So this is a bit of theoretical part. Usually, a ureteric colic has 3 phases, starting with the acute phase, which lasts for about 1 or 2 hours. And this is where the patient complains of a colicky type of pain, which is like going up and down. And then he or she moves on to the constant phase where they have a kind of a persistent pain, which lasts for about 4 hours. And then goes to the third or the last phase, which is the relief phase. So generally, patients present at this constant pace where you have the highest pain at all. And then a bit of theory questions to Melan. Why do you think that you get pain in a ureteric colic?
So because the ureter is a tubular
physiology behind it.
The ureter is a tubular hollow structure, and because of peristalsis against the obstruction, there can be transient ischemia when there is peristalsis against the obstruction in a hollow tubular structure. So because of that, there can be pain, and at the same time, because of distension of the ureter because of the obstruction, again there can be pain. So.
Good. So in simple terms, it's because of the muscular spasms of the ureter, which is a muscular tube, as you said. And most importantly, if you get loin pain, it's mainly due to the stretching of the renal capsule. So this is one theory that you should know. And then when you assess this patient with your clinical history and examination, your differentials narrow down to acute appendicitis and right ureteric colic. How are you going to move from there? In other words, what investigations would you consider to do from this point of view?
So if I have to exclude between acute appendicitis and ureteric colic, so I could first take a history from him and ask him if he has had episodes like this in the past that is suggestive of ureteric colic. So this could be another recurrent episode. And at the same time, I could do an ultrasound scan abdomen, because if I have to do an X-ray KUB, sometimes the bowel prep might not be adequate and I might not be able to see the stone clearly. An ultrasound scan abdomen would be useful in this setting.
Okay, so Melan, I'll stop you there. And one important point you brought up is like, if there is no bowel preparation, your X-ray KUB would not be very clear. Is that really true, or are we still practicing bowel preparation for X-ray KUBs? Anyone can answer. Is it really necessary to have bowel prep for X-ray KUB? Anyone else?
If it's a new evidence, bowel prep is not actually needed.
Yeah, exactly. So you don't need bowel preparation for X-ray KUBs anymore. And how much of, or what percentage of stones would be visible on an X-ray generally? In other words,
it's a radio stone, 90% of 90% of radiopaque
Wonderful,
stones
very
can
good.
be visible,
So,
but the sensitivity
yeah.
and specificity of detecting stones is around 45 to 55% on an X-ray KUB.
Yeah. And what other diagnoses or what other radiopacities would hinder your diagnosis of ureteric stone commonly in the pelvis?
On an X-ray, sir?
Yeah.
If there are other bony structures could be occluding the calculus, or at the same time phleboliths could also be mistaken.
Very good. So phleboliths are something which are commonly mistaken as stones in general surgical practice. So we usually get about 10 or 15 referrals a day saying that they've got ureteric or a bladder stone, but then generally they are phleboliths. So how can you differentiate phleboliths from ureteric or a bladder stone?
Usually, phleboliths have a radiolucent. In the center, they are supposed to be radiolucent. Phlebolith as opposed to a ureteric calculus.
Yeah. So how would you differentiate a phlebolith from a ureteric calculus?
And also from the passage of the calculi, we can look at the transverse processes and trace the track of the ureter. We would suspect a ureteric calculi along the tract of the ureter as opposed to a phlebolith.
Very good. So most common features that you would use to differentiate phleboliths from a ureteric calculus is the central lucency, which is seen in phleboliths, but not, as you said, you look for the pathway of the ureter and see whether the radiopacity that you're suspecting as a ureteric calculus is in the pathway of the ureter. So if it is away from the pathway of the ureter, you consider it as a the diagnosis of a ureteric calculus. Okay, so remember the radiolucency, the central radiolucency is one of the key features of phleboliths, and you should not miss that. Okay, so as you said, you are going to do ultrasound scan and an X-ray KUB, which is equally sensitive to detect ureteric calculi in clinical practice. So if you don't have any NCCT KUB, you can combine X-ray KUB with an ultrasound scan. So 90% of the stones can be detected with combination of these two imaging modalities. And in ultrasound scan, what are the other specific features you would be looking for in a suspicious case of a ureteric calculus?
So I can also look for any evidence of any upper tract dilatation in this case, sir.
Yeah, good. And what is the place for intravenous urogram in acute ureteric colic?
Usually, right now, so IVU is usually supposed to be obsolete procedure. That's not usually done anymore.
Very good. Very good. And going back, the gold standard after the combination of ultrasound scan and X-ray KUB is considered to be non-contrast CT KUB. Particularly in European countries, they are now moving forward NCCT KUB. But still, in the EAU guidelines, the first line investigation or imaging modality in a suspected case of ureteric colic or ureteric calculus is still an ultrasound scan and an X-ray KUB. But soon they will be moving towards NCCT KUB, which will help you to exclude other differentials as well. For example, with an NCCT KUB, you can exclude leaking AAAs, but that's not the gold standard for AAAs, but you can still have an idea as whether there's any evidence of AAAs. And also with a good radiologist or radiographer, you can detect dilated appendix as well, so that you can indirectly exclude acute appendicitis as well. But there are some cons as well with CT scans. What are the pros and cons of CT scans in acute setting when you're suspecting a ureteric calculus? Melan, any advantages and its disadvantages that you can discuss?
With the NCCT KUB, sir, we can get an idea about stone density, which
very good
may not, which we may not be able to get from the other modalities. So that will help us in subsequent management as well therapeutically.
Wonderful, that's good. And what is the method of measuring the density of a stone in a non-contrast CT? What
It's
is
with
the
Hounsfield
density?
units.
Very good.
With
Okay.
Hounsfield units.
Yeah, and this is something you might need to see if you are interpreting your own non-contrast CTs, but which is not done in Sri Lanka at the moment. So if you are a practicing urologist, or if you are a practicing general surgeon who is attending many cases of ureteric colics, you should know this sign in the CT, which is called the rim sign, which happens when you have an obstruction. There is a bit of edema around the obstruction, so at the ureter. So you will see kind of a ring around the the opacity, which is called the ring sign here. Okay, so a bit of another theoretical stuff, Melan. So you do renal function test at the presentation. So you do a serum creatinine level and a serum electrolyte level of this 45-year-old otherwise healthy man. And you find that the renal functions or the serum creatinines are slightly elevated in the sense, say if the upper normal range is 120, you find that the patient's creatinine is 160. Are you worried, or what is your inference here?
Yes, sir, we could be dealing with an obstructed system, which could be causing an acute kidney injury.
Okay. And why do you get elevated serum creatinine when his other kidneys functioning normally? Because he doesn't have any background history of CKD or his other kidneys functioning fine. But still, why do you get your serum creatinines elevated?
Not entirely sure, sir.
Sorry, say it again?
Not sure.
So this is something where you get confused as the kidney functions are drastically going down. It's actually not because of renal function deterioration commonly. If the patient doesn't have any other preceding history of CKD or diabetes or hypertension, this is just indicating that there's an obstruction, because when there's an obstruction, as you said, the upstream system gets dilated because of the increasing pressure. And because of this increasing pressure, there's a bit of urine seepage through the micropores in the ureter into the extraperitoneal space. And as you know, urine contains like 30 times creatinine compared to the serum. So your urine, if you check your urine, your creatinine levels would be 3,000 and 4,000. So a bit of urine leaked into the extraperitoneal space contains lots of creatinine, get reabsorbed into the system, so that your creatinine levels in the blood increases. That is the reason as why you get slightly elevated serum creatinines in an otherwise normal person who just is obstructed. Obviously, that means your kidney functions have drastically gone down. Do you get what I say?
Yes.
Hello?
Yes.
So it's basically because of the extra system causing elevation of serum creatinine, okay? And one clinical question. So you have a patient with a non-contrast KUB, we as urologists ask for an X-ray KUB as well when you refer the patient to us. Do you think that's sensible? So you have a patient coming with a non-contrast CT KUB done in the private sector, saying that he has got a 8 millimeter stone in the upper ureter. And when you refer them to the urologist, they ask, please do an X-ray KUB. Do you think that's a sensible thing to do?
Yes, so if you are planning on doing a procedure, it might be helpful with preoperative imaging.
Yes, and can you further explain why we need X-ray KUB to plan our procedure?
For example, if you are dealing with a upper ureteric stone, for example, there is also a place, if we are considering ESWL, for example, it's in the upper ureter. Wonderful, and we can get an idea about the size of the stone.
The stone could have moved downwards.
Because sorry, I didn't catch that. What did you say?
The stone could have moved downwards, so we need to know the current position of the stone.
Okay, if the NCCT KB has been done quite far back, yes, I agree with your answer. But as Melan said, the most important reason as why we are asking for an X-ray KUB is to decide whether the patient can go ahead with an emergency shockwave lithotripsy if the patient is an appropriate candidate for that. So as you know, ESWL, we target the stone using X-rays and then send the shock waves. So you need to have radio opaque stones for shock wave lithotripsy. Even if it is radio opaque, if it is very, if you can't see it with the X-ray, which means it's a smaller stone, so that you can't target your shock waves, then he's not a candidate for emergency lithotripsy. You may have not seen this practicing in here because we commonly don't do emergency shockwave lithotripsy, which should happen within 24 hours of presentation. But in a setting where you have all the facilities, the patients can undergo emergency shockwave lithotripsy for upper ureteric stones. So in such a case, you ask for an X-ray KB to see whether the stone is visible and whether it's of amenable size for shockwave lithotripsy. Okay. And so now you have found your patient is having a 6 millimeter lower ureteric stone on the right side. And how are you going to manage this patient, Melan?
So my modalities of treatment, I could go for medical treatment or failing which surgical treatment, but since this is 6 millimeter stone in the lower ureter, chances of it spontaneously passing are much higher. So I could start the patient, I could first start with lifestyle modifications and increased hydration, and I could give a trial of medical therapy and see. So.
Okay, very good. And can I slightly change the question? What would differ if you find a stone of 4 millimeter size? Would you be considering something else, or would it be the same management as for a 6 millimeter stone in the lower ureter?
It would still be the same.
So you would be using medical expulsive therapy, in the sense alpha blockers?
Since it's 4 millimeters, it would most likely spontaneously pass. It's a higher chance.
Okay, so yeah, well, what would you do? Would you give any medication, or would you just conservatively manage?
If he's in pain and symptomatic, then definitely I would consider pain relief. And there is a role for calcium channel blockers and alpha-1 blockers as well.
So would you consider giving alpha blockers for a 4 millimeter stone in the lower ureter? Is there any evidence for that?
not sure about the evidence.
Yes, the evidence says it's for 6 millimeter or more. So if it is less than 6 millimeters, you don't give tamsulosin or alpha blockers because it's the chances of passage is more than 94%. So even if you give tamsulosin, it doesn't increase much of your chance of passing the stone. So there's no point of giving tamsulosin. What is the problem with tamsulosin or alpha blocker?
It could cause a
For young
postural.
patients?
It could cause a postural hypertension is one.
Say again? So now this is a 45-year-old farmer. So postural hypertension is not for, yeah, exactly. So postural hypertension is more in slightly elderly, or if the age is more than 60 or so. But for younger people, they commonly come with retrograde ejaculation. So if the stone is in the upper ureter, what would be your, would it be the same management or does it differ? Say it's a $6 mm stone in the upper ureter.
For ureter, chances of it spontaneously passing are lesser compared to distal ureter. If the patient is symptomatic, then I could consider URS and ICS WL in this kind of a patient.
So yeah, so now you have to find out whether whether there is a chance of passage. So there's an objective way of assessing the chance of passage of stone depending on the size, site, and ureter. So there's an online calculator called MIMIC calculator, MIMIC calculator. This is this is based on surgical registrars or the national surgical trainees in UK, where you can put the size of the stone, the location of the stone, whether there's evidence of hydronephrosis and hydroureter, the WBC count, and whether you are using expulsive therapy or not, and then that will automatically calculate your chances of passage of the stone with or without tamsulosin. And for upper ureter, the chance of passage is generally around 70% for 6 mm calculi. And by adding tamsulosin, you just increase the chance of passage by only 3%. So if your chance of passage is 71%, by adding tamsulosin, your chance of passage just increases to 74%, just a 3% rise. So the reason behind that is the alpha blockers are commonly found in the lower ureter, not in the mid or upper ureter. So therefore, adding tamsulosin would not increase your chance of the passage. But what happens, why do we give tamsulosin or an alpha blocker, is when there is a significant chance of passage of the stone, in no time, the stone will come to the lower ureter, and that will increase the chance of passage from the lower ureter with an addition of an alpha blocker. So you should know the theory behind that, why we are giving tamsulosin, not to increase the chance of passage from the upper ureter, but to increase the chance of passage from the lower ureter. Okay? And most importantly, as you said, you need to give adequate pain relief. And then at what point would you consider other additional surgical procedures to relieve this obstruction? Or in other words, when would you consider to stent this patient?
Let's say if there is an obstruction, if there is an obstructed infected system, then he'll definitely need stenting, sir.
Wonderful. Yeah, that's one indication. What is the other indication?
Obstruction with acute kidney injury again.
Yeah, so that's an obstructed infected system. Okay. Any other indication for acute stenting? if the pain management fails, if it's refractory to all the pain medication, then there's an indication for stenting. But what is the problem with stenting here? What in other words, how would you counsel the patient for stenting? What would be the pros and cons of stenting?
Well, so it's a young patient, so the stent will remain in situ afterwards.
Yes, okay.
So have to mention.
Okay, but the stent, if you are stenting the patient should be offered clearance of the stone within 4 to 6 weeks. And then at that point, you take the stent off. But what is the problem between these 4 to 6 weeks from the time of insertion of the stent? Particularly in young patients?
They can be having, because he's a young patient, he might be having concerns about the stent being in situ, affecting his private life as well, social life.
Not really, but they will be having something called stent symptom, which is because of the, have you seen the ureteric stents or JJ stents? And
yes.
At the lower end, you have a coil inside. So that coil lies within the trigone of the bladder, most commonly. So that irritates your trigone, and the patients will be having increased frequency and lots of fluid symptoms. So those are called stent symptoms, and these are sometimes unbearable. So some patients would come and say, I would rather have the stone than this stent. So for young patients, you should always counsel about the risk of stent symptoms before subjecting them to stenting. Okay. And as you said, when you offer a stent, they should always be booked for removal of the stent and the stone, or any procedure to take off the stones within 4 to 6 weeks time, ideally. Okay, and this brought us to a point about appropriate pain relief. What pain relief would you consider for ureteric colic? And in other words, what would be the best pain relief for ureteric colic?
Nalin, sorry to interrupt. Are you moving your slide? So I think we are stuck at slide number 16. Is that correct?
Yeah, we are at slide number 16 now.
All right. Okay. Thanks. Good.
Melan, we were talking about what would be the best pain relief for.
Yes, I would follow the scale of the pain ladder. I would follow the scale of the pain ladder in offering him analgesia. So first I would start with simple analgesics, and if not responding, then might have to go for even analgesics like morphine or tramadol.
Yeah. And in other words, so for acute ureteric colic, if there are no other contraindications, the best a suppository of diclofenac or some other NSAID. Okay, and these things we discussed so far, and these are the indications of the stenting. As we said, if it is an obstructed infected system, it's one indication, and the other one is refractory pain. Thirdly, if you have a single or solitary kidney with an obstruction, you have a very low, threshold for stenting. So always consider stenting if you have a single obstructed system. And if you have bilateral obstructing calculi, you generally consider to stent, because to save the kidney functions and in the ureter. So at which point you should not consider conservative or medical expulsive therapy, because the chances of passage of all these stones altogether is lesser. Therefore, you should consider an active treatment at that point. Okay. And as you said, if the patient is unstable, say the patient comes with an obstructed infected system and the patient is not fit to go into the theater or go under anesthesia, what should you consider?
So the other option is to go for percutaneous drainage. So that does not require anesthesia. So we could go for the percutaneous drainage if the patient is hemodynamically unstable.
Yeah, because it's done under local anesthetic. You can always go even for slightly unstable patients as well. But always, you need to resuscitate the patient, make him stable to be transferred across to the interventional radiology suite to undergo percutaneous nephrostomy. Okay. And can someone take the next? Very good, Melan. Can someone take the next case? This is a quite quick one. Any volunteers? Azim, Hizam Hanifa, Dr. Hizam Hanifa. No. Dr. Madhushan Edil Singha. Okay, I think, I'll go quickly through these slides because no one is interested in taking the case. So this is about urolithiasis in pregnancy. This is one of the cases that are commonly discussed in your exams, either in MD or in urology exams. So one important thing about urolithiasis in pregnancy is it's something that we think is uncommon, but generally it's very common after 22 weeks of pregnancy. So the management is different in each trimester. So if the patient is coming with a ureteric colic at the 3rd trimester, you have lesser threshold for treating because there is a chance of premature delivery if you don't treat the patient. But most importantly, the dilemma is when a patient comes with a history suggestive of a ureteric colic, what investigations should we do? So the first line investigation or the emerging modality in pregnancy is ultrasound scan, but sometimes you won't be able to find any stones in the ultrasound scan because of the fact that there's a gravid uterus, and that will obscure your weaves in the lower and mid ureter. So at which point you consider MR urography or a low dose CT. Out of these, the EAU guidelines suggest that low dose CT can be used in 2nd and 3rd trimester safely. So if all the other modalities are out of the scale, you should always consider low dose CT, which carries a lesser risk to the fetus. So this could be an MCQ in your exams, whether we can use low dose CT for patients who are suspected to have ureteric colic during pregnancy. Okay, and as you know, there are some physiological changes during the pregnancy where you can have hydronephrosis and hydroureter, which is called the physiological hydronephrosis and hydroureter in pregnancy, and this can be misleading you because you might attribute hydronephrosis and hydroureter due to an obstructed system, even for this physiological hydronephrosis and hydroureter. Therefore, you should be very careful in attributing the hydronephrosis that you detect to physiological hydronephrosis. You should always try and find out whether there's a cause for this hydronephrosis and hydroureter before attributing them to stones. And as you know, there's an increased risk of lithogenicity during the pregnancy because of these factors that I've mentioned in these slides. I can send you across these slides if you want. I'm not going to read them. It's going to be boring for you if I read. And that is another thing that we can use during pregnancy to detect whether there's an obstruction and to exclude physiological hydronephrosis and hydronephrosis during pregnancy is to use the resistance index in the ultrasonography, which will give us an idea whether it's due to obstruction or whether it's because of the physiological hydronephrosis and hydronephrosis. Generally, if your resistance index is more than 0.7, that indicates an obstruction rather than physiological hydronephrosis and hydroureter. And with a good ultrasonographer, they can closely monitor whether there's a urine jet coming through the ureteric opening in the bladder, but this has to be this asymmetric urine jet in the ureteric openings. And that is very sensitive and specific if you can detect asymmetrical urine jet from the UOs. That will indicate an obstruction. Okay. And as you know, you should never give NSAIDs during, you should not consider NSAIDs during pregnancy because it's contraindicated. And one question that most of the people ask is about tamsulosin or alpha blockers, whether we can give tamsulosin during pregnancy. The answer is yes. That's a category B level safety for alpha blockers during pregnancy. Okay. I think that's it. Any questions about ureteric stone? I know this is not perfect because half of my slides are not here. So I'm sorry about that, but any questions or anything that we missed? In the absence of questions, can I hand over to Gihan, please?
Yes, Dr. Thank you. Can you hear me? Hello.
Hello. Yeah, we can hear you, Gihan.
Yes, thank you. Let me share my slides. Can everyone see my slides?
Yes, Gyan, we can see.
Yes,
Yes, Gihan, we can see it.
For this case, I would like one of the registrars to join me with the discussion because I specially prepared this for the registrars. Can someone join me? Let's check. Second. Let's see. Dr. Lahiru Karnaratna. Hello. Hello. Hello, can you hear me?
Yes, Gyan, we can hear you, but
yes. Can someone join me with the discussion? Because
yeah, please someone join. Otherwise, it's going to be very boring, and it's a good opportunity. So
especially the ones who are preparing for the exam. Let's see. Tisura Vittane. Sudat Priyadarshana. Okay. So the case is a 45-year-old female with diabetes, admitted to surgical casualty with a history of 3 days of loin pain and fever. So how would we evaluate the patient? Can anyone answer? Okay, so moving on, in the history, we have to look at the differential diagnosis because I think this is a common case with abdominal pain which comes to the exam. So even though you tend to think about renal problems in the start of the questioning, we have to think about other differential diagnosis as well, because most likely the case can be about renal problem, renal infection in this case, but if you miss something else in the discussion, that's not going to look good on you. So we will start with evaluation of the pain. Everyone know about how to evaluate the pain, and then also the fever. And also don't forget associated GI symptoms. The patient might be having a jaundice or features of cholangitis. And it may not be a case of renal infection. So you have to complete all the parts in the history that in a normal case. And then most importantly, this pyelonephritis occurs in more in females and also more in comorbid patients with diabetes and also immunocompromised and CLCD patients. So those things should be gathered from the history because that will have a more bearing in the management, subsequent management. And also in the past medical and surgical history, you can ask about the previous history of stone disease if you are suspecting this is a renal infected system. And then you can move on to a relevant examination. So this infected obstructive system, as Dr. Nalin discussed, can present as a severe deteriorated patients in the patient can be in a shock state when it comes to the emergency department. So it's important even you in the exam that you think about the resuscitation first, assess the airway breathing and circulations, just to mention that. And also do the proper abdominal and general examination in line with your resuscitation. Especially the patient may not be able to tolerate your examination or anything because the patient may be in severe condition like with altered mental status and a shock. So resuscitation starts with parallel with your history and examination. So like general severe case, you start with white bore cannulas, oxygen, and bloods for cultures, as well as full blood count and your coagulation profile plus other investigations, CRP. And then you also start with the catheter to drain the system and start monitoring of the organ perfusion. And don't forget your sepsis protocol and even the ABG. And then you move on to your investigations, extra KUB and the ulcer KUB, because you are thinking that there may be a renal infection. And of course, these are the findings. The patient has a pulse rate of 120, temperature 102, blood pressure, systolic blood pressure 80, and respiratory rate 20, and blood sugar of 400. And you get X-ray KUB, and this is the X-ray KUB. Can anyone answer what describe what you are seeing in the X-ray KUB? Vinodya Ranavira, Dr. Vinodya. Is anyone doing the exam this year? Okay. I think everyone is tired by now. So I will continue. So as you can see, there's a right side kidney showing edematous, and there's gas inside the renal parenchyma. And also there's concentric shaped gas around the kidney. So these are classic signs of emphysematous pyelonephritis. So most commonly they are coming with diabetic patients. There may or may not be a stone. Sometimes it's just a papillary necrosis which have obstructed and causing this. Sometimes even without a papillary necrosis, just a pyelonephritis which has gone beyond into emphysematous pyelonephritis. So they come after weeks, maybe referred from the medical ward. They are managing a pyelonephritis which is unresolving. And when you get the X-ray KB, you see this. And just to mention that you can also see some renal stones on the left side. Most likely it's one looks like a stone and the other one may be a fibroid, but they can have some stones. So in this case, if you are going to do something, you might think about doing bilateral stenting or even doing a CT before doing that, just to identify whether this is a stone or not. And so what is emphysematous pyelonephritis? I just wanted to discuss this case of emphysematous pyelonephritis because pyelonephritis we commonly see and it can be managed with antibiotics and general measures, but emphysematous pyelonephritis has a high morbidity and mortality. So it's important to identify that necrotizing infection of the kidney as well as the surrounding tissues. That is why it's given a special name. And if not treated early, they can lead to fulminant sepsis and therefore they have a high mortality. So in examination, in very advanced cases, you might feel any crepitations in loin area, but this is very rare, but it can happen. And also they can have some pneumaturia in the history. Apart from that, it's basically a diagnosis by our investigations like X-ray, KUB, ultrasound scan, as well as for the definitive diagnosis, we will have a CT scan. As this is a severe fulminating infection of the kidney, most likely they will come with the acute kidney injury as well. So it's unlikely that they will have a contrast CT, but the non-contrast CT is good enough. So why we do non-contrast CT is to identify the categorization or the severity of the emphysematous pyelonephritis, as well as to identify any precipitating cause like a stone causing obstruction or even a papillary necrosis. So common organisms is just like the common UTI, gram negatives. Klebsiella E. coli is the most commonest one, about 70%, and Klebsiella pneumonia and Proteus mirabilis. And also there can be very rarely fungal infections. So thinking about next management sequence, when you're answering a question, you have to think about after resuscitation, initial starting with resuscitation, including hydration, IV fluid resuscitation, and systemic antibiotics. You have to monitor the resuscitation, whether the patient responds or not. That's why the catheter is in there. And that's why the monitoring, the patient is attached to the monitor and you are continuously monitoring the vitals. And if they're not improving, you have to move to the next step of management. That means correction of blood pressure with inotropes and continued fluid resuscitation with the management of electrolytes and glycemic level. This is very important because these patients are diabetics. And not only the renal failure, they can also be in a state of ketoacidosis. So before you start doing anything, the patient can die with a elevated level of potassium or electrolyte imbalance. So it needs correction as soon as possible. and that will also control the sepsis. So if the patient is in a bad condition like that, think about escalating the level of care. So you can tell about these words, escalating the level of care. So the patient, if he's going into 2 organ failure or 3 organ failure, if there is thrombocytopenia associated with elevated creatinine and altered mental status, it's very unlikely that you will save the patient in the ward or even in the HDU. So you have to escalate the level of care soon enough, reserve a bed in the ICU if you're sending patient for any intervention, or even the intervention can happen after the patient is resuscitated in the ICU. So think about escalating level of care as soon as possible. And then for the proper diagnosis, like I mentioned earlier, we can do advanced imaging with the CT abdomen is available. And that will also focus severity and secondary cause. And most importantly, next step of your management is the source control. Of course, as long as if there is any obstruction and not relieved, the patient is going to deteriorate. So it can be done either internal stenting, and in this case, there can be some gas collection outside. So you might need drainage from that side also. So percutaneous drainage plus internal drainage is okay for the stable patient in the initial setup. So if you look at the CT, there is a destruction of the renal parenchyma. And also there is gas collected in the perinephric space, and the Gerotas fascia seems to be intact. So there's a CT showing gas collections or confirming the emphysematous pyelonephritis, and there may be fluid collections, and so there may be abscesses formation. And then if the Gerotas fascia breached and the gas extend into the surrounding space, the severity is more. And also there can be bilateral diseases in some cases. So CT classification, there's one saying classification, class 1 showing gas in the collecting system only, class 2 showing gas in the renal parenchyma only, class 3A, renal parenchyma with extrarenal extension. So in the CT previously shown, it's like class 3A disease, and also class 3 disease into pararenal space. And class 4 bilateral emphysematous pyelonephritis. As you can understand, when the class increases, the severity increases. And our management options initially favoring the conservative management like percutaneous drainage and the internal stenting, plus IV antibiotics and resuscitation. But when the class increases, the early nephrectomy would be the salvage for the patient, because the patient might deteriorate even not fit for a surgery after some time. So it's important to identify this condition early and go for nephrectomy if it is necessary. So regarding conservative management, we consider conservative management mainly in the early stages of emphysematous pyelonephritis, or you call it pyelitis, where there is only gas in the collecting system or in the kidney, only part of the kidney. And the patient is okay, stable, and he's responding to resuscitation. In that case, we can continue our conservative management and see. But if the patient conservative management fails, of course, the next available option would be the nephrectomy. And regarding the antibiotics, after sending cultures, we cover broad spectrum antibiotics, especially targeting gram-negatives. So initially 3rd generation cephalosporins plus aminoglycoside, usually amikacin 1 gram stat and cephalosporin. But sometimes the patient, as I said earlier, they come with renal failure. So aminoglycoside may not be a good idea at that point. So they might need carbapenem straight away, like meropenem. And contact microbiology early in case if we're suspecting any other cause, like a fungal infection comes out in the blood cultures. And generally, you have to continue antibiotics even after patient improves for 2 weeks. And late complications can occur like residual abscesses which need drainage afterwards. So indications for nephrectomy. Mainly it is the failure of conservative management, but like I mentioned earlier, in the onset, we might think about doing the nephrectomy in patients who are in severe cases of emphysematous pyelonephritis. And if there is no access for percutaneous drainage or internal stenting when we are working in a peripheral unit, then the nephrectomy may be the salvage for the patient. And there's dry tie PPN, that means the gas pattern or the necrosis occurs in renal parenchyma without any areas tend to deteriorate with the conservative management, and they might need nephrectomy early. And even class 3 and 4, if there is class 4 bilateral emphysematous pyelonephritis, we might consider conservative management just to preserve the renal function. But in any case, even if the patient deteriorates, they might need bilateral nephrectomy even. Classification, if the patient is in class 2 and class 3 with more than 2 risk factors like diabetes mellitus, thrombocytopenia, altered level of consciousness, shock, and acute renal failure. So all these things show different organ failures, different organ systems. So if there are more than one organ system is affected, then you might consider doing early nephrectomy to salvage the patient. So if I summarize, usually emphysematous pyelonephritis occurs in a diabetic patient admitted with a fever and history of urinary tract infections, maybe a couple of weeks. And you can start conservative management or supportive management with percutaneous drainage after the CT scan confirming the emphysematous pyelonephritis. However, if it fails, you go for the nephrectomy. But if there is the patient has a single kidney or we need to consider preservation of renal function, then again you can consider conservative management. But in deterioration, patient need nephrectomy. And unstable patients straight away go for resuscitation, and following the resuscitation, patient need nephrectomy. So it's important to identify the nephrectomy plays an important role in the management in emphysematous pyelonephritis, although the patient comes from the medical ward or anywhere else. And it's important to identify this, otherwise you might lose the patient if it is not timely managed. Okay. So that concludes the case. Any questions? Any questions from anyone?
You may ask any questions with regard to the presentations today, if you have. So I think all are tired. So
yeah, I think
in the absence of further
time.
questions, and shall we conclude the session, Gihan?
Yes,
so,
I think so.
Yeah, I would like to thank Dr. Sanjeev, Dr. Nalin, and Gihan for the excellent presentations. And thanks Dr. Kalana and Dr. Munipriya for coordinating this with the College of Surgery. And thanks for this wonderful opportunity. So I hope you had a good day and have a rest of the evening pleasant. Right.
Thank you, Dr.